Hello everyone. We are now going to go over the flow cytometry plots from the axillary lymph node of a 38-year-old woman with lymphadenopathy. So let's start with CD45 versus site scatter. This is a lymph node specimen, so we expect all our cells to be lymphocytes in a lymph node specimen. There may be a few background monocytes and granulocytes. So just like we expected, we see that majority of our cells are lymphocytes with almost no monocytes or granulocytes in this specimen. So our lymphocytes show bright CD45 expression and have low site scatter. Now let's follow through these cells. In the CD20 versus CD10 plot, we see that our lymphocytes are positive for CD20 and they express CD10. So even though lymph nodes will have germinal centers and CD10 positive cells in the germinal centers, we don't expect all of them to be CD10 positive. There may be a small population that is CD10 positive, and those cells usually express brighter CD20. But this is clearly abnormal. You're not supposed to see all of the lymph node cells to be CD10 positive. So this is abnormal, and they do not express CD34. This is important because not only mature B-cell lymphomas, certain mature B-cell lymphomas, immature B cells also express CD10. So if you remember, your B lymphoblasts usually express CD19 and CD10. So any time you see a CD10 positive B cell, you should always make sure the population is mature or immature. And there are certain clues to that. One, immature cells will obviously express immaturity markers like CD34 or or TDT. And two, in CD45 versus site scatter, they usually sit in the blast gate. That is, they have dimmer CD45. Here they are bright. And number two, the other one is CD20 would be usually dim or heterogeneous in the blast population. It is bright and homogeneous in mature B cells, but don't go by that because very rarely blasts can have a bright CD20 expression also, rarely. It's not a reliable thing, but it's good. It sometimes helps. And the other thing is surface light chain expression. Lymphoblasts are immature cells, and they do not have surface light chains. And your mature B cell lymphomas will have such surface light chains, and they are usually restricted. So here, if you see in kappa versus lambda, we see that all the mature B cells are lambda restricted. There are some scattered kappa positive B cells in the background, but majority of the B cells or majority of the cells of interest are lambda restricted. So we have a lambda restricted CD10 positive B cell population in the lymph node in a patient with lymphadenopathy. So there are a few things that would come to our mind. CD10 positive lymphomas, which means lymphomas arising from germinal centers. So the most common ones are the follicular lymphomas and diffuse large B-cell lymphoma from germinal center origin. And even Burkitt lymphomas are from the germinal center, so they also express CD10. So Burkitt's and diffuse large B-cell lymphomas and high-grade follicular lymphomas are large B cells, are composed of large B cells, so they usually have high site scatter. But sometimes, those large B cells disintegrate so faster. So this is a very helpful element. Having low site scatter helps saying that these are probably just low-grade B cells. So possibly this is just a follicular lymphoma, but do not go by that. So far, we know that this is a CD10 positive B cell lymphoma. And these are negative for CD71. And again, here, these are negative for 34. And they are negative for 103. 103 is a hairy cell leukemia marker. These are negative. And CD38 is partially positive on these neoplastic B cells. So CD38 has a prognostic value in CD5 positive lymphoma, in CLL. But here, normal germinal center B cells also express CD38. So CD38 expression in a CD10 positive population is not of prognostic significance, but it is usually positive. They go along together usually. In the second tube, we see that these neoplastic B cells are negative for CD5, they're negative for CD23, they're negative, they have partial FMC7, and they're negative for CD200. So this is along the lines of what we expected. There is nothing, nothing that changes the diagnosis here. So from this case, this is again kappa versus lambda plot that shows that the B cells are lambda restricted. So in this case, you will top line it as CD10 positive B cell lymphoma, and then you will give in your comment that these are smaller B cells, and you can suggest that this is probably low-grade follicular lymphoma, but definitely do not put follicular lymphoma on your top line because that is a tissue diagnosis. And sometimes we have large B cell lymphomas that has like medium-sized B cells. So, you can very rarely we can be fooled by that. So let's not say that in the top line. Just say CD10 positive B cell lymphoma. And rarely follicular lymphoma, especially the floral variants, can be CD5 positive also, and those are associated with poor prognosis. CD5 expression is associated with poor prognosis. One other thing is CD23. Its utility in the tissue is usually to see follicular dendritic cell markers, but rarely follicular lymphoma cells themselves can express CD23 on their surface. Sometimes immunostains, when if it is crushed, or so it may be hard to interpret if the CD23 expression is on the cells or on the meshworks. Flow helps in that regard. So when you write your report, always document all the markers. And one thing to remember is if you see positivity of CD23, document it. So the final diagnosis on this case turned out to be follicular lymphoma, and this is a classic CD10 positive B cell lymphoma. Thank you.